Thank you first for inviting me to have a talk here at this meeting. It's a great honor for me, and especially with Chairman Doug Altman. So I hope I can work with this method here. Okay, so Doug Altman 20 years ago published this editorial, I guess, in the BMJ, The Scandal of Poor Medical Research. And of course, since this time, we had surely some improvement in research and in methods of research. For example, the establishment of the Cochrane collaboration and similar institutions. But still, we have, I think, some problems with evidence at all. For example, take the evidence for the treatment of localized prostate cancer. And here, of course, I'm just talking about RCTs, nothing else. And here, especially RCTs for the comparison of different strategies to treat these patients. And you should bear in mind that in Germany alone, or in Germany only, about 40,000 men are affected each year with this disease. 40,000 men each year. And that's the evidence-based. The evidence base is, in principle, one study from Scandinavia, from Sweden, which started in the late 80s of the last century. And it doesn't cover the patients which are affected now, who are detected by PSA screening. That's the evidence. Worldwide, 700 patients for a disease which affects every year alone, only in Germany, 40,000 men. So I think this is also a scandal of no evidence at all, or no medical research. I tried to highlight some challenges we have at the moment in the context of health technology assessment. And it's only a few examples, and it does not cover all the challenges we have, but I think they are one of the most important problems we have. First challenge is the use of surrogates. Here is a recent review of the approvals in the United States of drugs in oncology and hematology. And what we see that of 43 new indications, there are just 10 approvals based on overall survival. And in principle, the rest, 80%, is based on surrogates. So, as you know, this is a prominent statement from Fleming. It's just also 15 years ago. He said, a correlate does not make a surrogate, and as Baker here nicely presented, even a perfect correlate does not make a surrogate. So, what does this mean? This is a statement from systematic review in the Statistics Medicine, who looked for methods for validation of surrogates. And the important statement here is that what is required is not the correlation between the surrogate and the interesting endpoint, but what we need is the correlation between the effect of treatment on the surrogate and the effect on the interesting endpoint. And this is a great problem. And I think one nice method to take this into account is this approach with the surrogate threshold effect, which means that, or which is defined as the minimum treatment effect on the surrogate, which is necessary to predict a non-zero effect on the true endpoint. And this is an interesting approach, and it's presented here, an example of ovarian cancer, the progression-free survival as a surrogate for overall survival. And if you have these studies where both are assessed as well, the surrogate as well as an interesting endpoint here, overall survival, you can make such calculations and graphs, and if you have enough precision, you can determine a threshold where you are sure with an effect on the surrogate that you also have an effect on overall survival. This is a nice approach, but the problem is, in this example, you don't need the surrogate, but it's so close to the interesting endpoint that it doesn't matter. And again, Thomas Fleming, who said 6 years ago, the problem is mostly it's easier to show directly the effect of an intervention on the clinical efficacy endpoint than actually to validate the surrogate. This is a pity. This is a problem with surrogates. Another problem. Usually, we want to see, if we have competing interventions, we want to see direct comparisons. Because the statement here from Ioannidis, direct randomized comparisons of treatments are usually more trustworthy than indirect comparisons. Most people would agree with the statement. But is it really true? Here's a nice example from schizophrenia, where you see a prodrugs, because one drug A, beats drug B beats drug C, and drug C beats drug A. This doesn't work. So these are examples from direct comparisons where we have obviously a problem with the adequate composition of the comparator. These are industry-sponsored studies, and you can imagine what happened in these studies. So I don't think that always direct comparisons are helpful. Okay, if we use indirect comparison, because we have so a lot of examples where we don't have direct comparisons, we have to use indirect comparison if we want to make any assessment, then we have to face with the methodological problems. And here's a nice paper, again with Doug Altman as a senior author, just 2 years ago in the British Medical Journal. What are the methodological problems? And what you can see here very nicely, here are the basic assumptions. So, you know, an indirect comparison means we want to compare intervention A with intervention B, but we only have studies which compare A with C and B with C. So we have a common comparator, C, that could be a placebo. If we do a normal meta-analysis of all these studies, for example, comparing A with C, you know we need homogeneity between the trials. Then we can interpret the results. So if we now make an indirect comparison for the studies for A with C and B with C, then we have another assumption, another requirement that the trials are as far as possible similar. This is difficult to assess, but this is a basic assumption. Otherwise, we have a confounding. That's trivial. But if we, at the next step, we have indirect and direct comparisons, what we call now mixed treatment analysis, or mixed treatment analysis, then we have another assumption that we have consistency between the indirect and direct evidence. And in this paper, the conclusion was that most people, or in most papers who presented results of indirect or mixed treatment comparisons, that they didn't have any idea of the underlying assumptions. And this is, of course, a problem, and then we cannot interpret the results. So the adequate understanding of basic assumptions underlying indirect and mixed treatment comparison is crucial to to resolve these methodological problems. Okay, and just a very actual result of a systematic review in this field is that more than probably thought that there are discrepancies between the effects in indirect and direct comparisons. So it's only adequate to mix such indirect and direct comparisons if there is an adequate assessment of the consistency. Another challenge is the assessment of diagnostics. The crucial question is whether such images might be deceptive. It's nice. You can get very, very pretty pictures from these new machines, which are pretty, pretty expensive, as you know. But what do they tell us? So for the diagnostic accuracy, we have a very, very smooth or very, very sophisticated method at the moment. So we can produce such nice summary receiver operating curves, SROC, or we can perform bivariate meta-analyses, which are very complicated to calculate. But what does us help? What does this help? On the other hand, there's a nice statement from the great working group, and they clearly say that whatever the accuracy is, the diagnostic test has a value only if the results, the test result, or if the application of the diagnostic machine results in improved outcome for the patients. And this is not obvious from these diagnostic accuracy results. So the problem is that people in this area, especially the clinicians, don't think that it's necessary or even applicable to use, for example, randomized controlled trials to assess or to look for the benefit of the application of a diagnostic measure. And but maybe the direct comparison of the application of a diagnostic versus not the application of the diagnostic may not always be the true and interesting method of assessing the benefit. I would like to show here my view how to assess the value of information and what is the essential information mean, or the essential essential information we have to gather if we look, for example, for a diagnostic. We have a population and we get informations, for example, through a diagnostic test from this population. One half has, for example, a marker positive, the other half a marker negative. And then we can look in a very general way on consequences. We have alternatives, A and C. For example, treatments, active treatment and placebo control. And then we have to look whether, if we compare these consequences or treatments, what is the effect in the one group, with marker positive patients, for example, and in the other group? We have two effects. And if these effects differ, this is what we call an interaction. And if we have, for example, a very big effect on the one stratum and no effect or even a harm in the other stratum, this is what we call a qualitative interaction. And this is what we, in fact, need to have. Then the information has a value. Maybe we have a quantitative interaction. This may be large. Then probably we also have a benefit of this information, from this information. If the interaction is small, probably we don't have a benefit. And if there's no interaction, we don't need this information. And you can apply this, as I said, to a diagnostic information and for a subsequent treatment decision. And then the diagnostic information guides the decisions. And if you take this as a framework for evaluating diagnostics, then you are clearly coming to the right study designs. And to be honest, I don't see any role of diagnostic accuracy within this framework. So here's a nice example from the German study to optimize the primary treatment in advanced Hodgkin lymphoma by use of positron emission tomography. And what they are doing is that they are stratifying the patients in, that's in German, I'm sorry, in PET positive and PET negative patients. And in PET positive patients, they try to escalate the treatment. So they have a superiority question. And in PET negative patients, they try to make the treatment less invasive. And there they have a non-inferiority question. And I think this is a very good example how to evaluate the value of PET for this clinical question, because if it works, if they can show superiority in the PET positive arm and non-inferiority in the PET negative arm, of course PET will guide the treatment decisions. So finally, next challenge is the question of value-based pricing. Maybe you know that we have in Germany every year a healthcare reform. And last year we had our last reform, and we got a new law on assessing new drugs on the market. And within these reform and this new law, there's a regulation on the benefit assessment of drugs. This is our code book, the law. So, and what we have to do is to assess the extent of the added benefit. And we have to quantify this. And we have to say whether there is a major added benefit, a considerable added benefit, a minor added benefit, or it's unquantifiable, or there's no added benefit, or less benefit. Here of special importance are the first three categories. How to differentiate a major from a considerable from a minor added benefit. But they are very nice. They gave us some examples in this regulation. They told us that a major added benefit could be, for example, a major increase in survival. And a considerable added benefit could be a moderate increase in survival times. So what's the difference between a major and a moderate increase in survival? Or a not moderate increase in survival? So what we have done, I can only show it very, very shortly, and I don't explain this complicated table here. What we have done is we have two components. We have a qualitative component in terms of the severeness of the endpoint, survival, morbidity, quality of life, major morbidity and minor morbidity. And we have these three categories: major, considerable, and minor benefit, added benefit. And this is a qualitative component, and we have introduced a quantitative component that we have decided to say, if we see in a study nearly a hazard ratio of 0.5 for survival, we are talking about of a sustained and great improvement. That means a major benefit. And if we see a hazard ratio of 0.83, we take this as a considerable benefit in terms of survival. And we don't look at the point estimates, but we have translated this into shifted hypothesis. And this is very, very actual. We have published it at our website at the moment, unfortunately only in German, and we will discuss this approach in the near future. So, I come back to the beginning at the end. I gave you the example with prostate cancer treatment. And for a few weeks ago, this was stated in the New York Times. And a man is talking about his discovery 4 decades ago. And he's very, very sad that this discovery led to such a profit-driven public health disaster. Public health disaster. You can imagine what he has meant. It was a discoverer of the PSA. PSA screening. So, now we were asked to ask you an interactive question. And again, I come back to this beginning of the end. First of all, thank you very much. And now, these are the results, the 15 years results of the Swedish study I showed you at the beginning of my talk. And what you see is that of radical prostatectomy really decreases mortality, overall mortality and death from prostate cancer. That's very nice. It works. But these patients in this study are not comparable with the patients of today. because patients of today are discovered by PSA screening, very different patients. They tried to make a subgroup analysis with so-called low-risk cancers. And here we have a very, I think, interesting but also disturbing result. In low-risk cancers, overall, or death from any cause is reduced by 13 percentage points, which is a lot. But death from prostate cancer is only decreased by 4 percentage points. So my question to you is now, can you explain how radical prostatectomy prevents non-prostate cancer-specific death in these patients? For example, how can prostatectomy prevent from death from myocardial infarction or from stroke or from whatever? I don't know. And the authors didn't mention this in their article. So now you can say yes or no, if you can explain it. Give you a few seconds. The result is we are close together. You cannot explain it as me. Thank you very much for your attention.
Do you think healthcare systems are encouraging bad behaviour in this continued state of poor evidence by trying to work with poor evidence? Why don't we just throw it in the bin and say, I'm sorry, this is not good enough. I'm not even going to make the assessment or consider the treatment if the evidence is poor.
I didn't understand your question, definitely. What is your question? What shall we do with it?
There are ongoing problems with poor evidence. We still, we see trials that, small case series and things like that. By accepting it and trying to work with it and coming to a conclusion with these evidence, wouldn't it be better just to reject it and say, if it's not good, it's in the bin, I'm not even going to consider looking at that treatment until you provide me with higher quality evidence? Because I think this continued state of poor evidence, we're reinforcing it by trying to come to conclusions about it. Is that any clearer?
So, when I understood you correctly, you said how to deal with this problem of poor evidence. And if we for example, we just had a report on special treatment for prostate cancer, brachytherapy, for example. And of course, we had very, very poor evidence for this assessment. And then we said, no, we cannot recommend this procedure, and we have to wait for better evidence. And for example, there are now a few studies underway for the treatment of these patients in early prostate cancer, especially in Germany. The result of our report was that there were collaboration now to make a study with about 7,000 patients. So I think the consequence should be to come to negative decisions concerning, for example, reimbursement. I don't know whether I fit your question.
I mean, I agree. The answer should be no. And quite frankly, if the evidence is poor, I wouldn't even go necessarily through a long process of doing the assessment. I'd just probably throw it straight in the bin if I had the choice. But quite often in the UK, we are introducing treatments despite poor evidence. Medical devices being one of them.
Oh, that's a problem in Germany too. And the problem in Germany is in particular because we have different ways to come into the system. And it's the IQWiG is something like NICE in the UK. IQWiG is a sister organization, one could say, in Germany. Not at all, because the decisions are made by another institution, but we are working close together. But we have pathways. And if we make strong decisions not to introduce a specific intervention, for example, in the basket, then there are pathways or bypasses is the right word, to come through another way into the system. So this is a little problem in Germany.
I suspect this is a question more for Fiona Godley, but it does beg the question, how do journals accept a lot of these papers? We get papers with relative risk, we get papers with discontinued trials early, we get bad papers, we get papers which should have riders on them, and therefore really isn't this part of the peer review editorial process which is failing us?
I think it's not a question for me. So I'm not an editor.
Yeah, I mean, I don't think Fiona's here, so I'm not going to answer on her behalf. But yes, I mean, all the stuff that people talk about, all the thousands of papers that systematic reviewers have to wade through, which is often very hard work, many of them shouldn't have been published, at least in the form they were published. But one could even argue that many of them should not have been done, and they've all been passed by ethics committees. It's a very deep problem. And the first question was about whether we're encouraging the maintenance of that situation by working with substandard evidence. And I guess to an extent we are. I think there is, okay, well, just quickly, one more comment from there, and then we'll close, or question.
Thank you. Really enjoyed your talk. One aspect of health technology assessments, obviously, cost effectiveness that you alluded to in your value-based pricing slide. And I just wondered where you see cost effectiveness as an assessment moving along with your other discussions.
Yeah, okay, I missed to say that these assessment or categorizing of the extent of benefit is the basis for price negotiations between the health insurance funds and the companies of the drugs. But we have no formal cost effectiveness analysis before these negotiations. If there's no agreement on the price, then afterwards we can be commissioned for a cost effectiveness analysis. But at the moment, the role is very, very limited, especially in Germany.